All right, good afternoon, everyone. Thank you so much for being here. Welcome to the second Healthier Washington quarterly webinar series of the year. Today's topic is tribal health systems and Medicaid transformation. How is this working in Indian country? So before we get started, let's make sure that we're connected properly. We've muted everybody, which means that we can't hear you, but you can hear us. There's going to be a Q&A, a question and answer session at the end of the presentation, but please feel free to send us your questions throughout the webinar. You can ask questions by typing them out using the panel on the right side of your screen, just like how we have it queued up in this slide. And we're also recording this webinar. So in a couple of weeks, we'll send you a link to the webinar recording and provide the slides from today's presentation. Also, if there's some questions that we're not able to get to because we run out of time, we'll make sure to have those questions answered in that email as well. Okay, so today's panel. Our panelists today are Sue Birch, the Director of Healthcare Authority, Jesse Dean, who's our Tribal Affairs Administrator for HCA, Vicki Lowe, who is the Executive Director of the American Indian Health Commission of Washington State, Aaron Spark, who's the Government Affairs Officer for the Seattle Indian Health Board. I want to thank all of you for being with us here today and sharing your knowledge and your expertise. I'm Rochelle Olanji, and I'm moderating today's webinar, and I'm the Health Transformation Communications Manager here at HCA. So Sue's going to start us off with a land acknowledgement that testifies to the unique and enduring relationship between the Washington tribal governments and the state of Washington. Sue.
Thanks, Rochelle, and thanks everybody for being with us today. I'm sitting here in Olympia, which sits within the traditional territories of the Coast Salish people, specifically the Nisqually and the Squaxin Island peoples. Olympia and the Puget Sound region is covered by the Treaty of Medicine Creek, and this treaty was signed under duress in 1854. Jesse, Vicki, and Aaron, our esteemed colleagues, are in Spokane, being hosted by the Native Project in traditional territories of the Spokane and Kalispel peoples. These lands are covered by executive order, not by treaty. Now, as employees of the state of Washington, we're all guided by the Sentinel Accord and by state law, which respects tribal sovereignty and affirms government-to-government partnerships between tribes and the state. Please join me in acknowledging the tribal governments and communities in these regions, including past and present tribal elders and future generations. Oftentimes in our healthcare work, we speak at the policy level, or we use language that disconnects us from the people we serve. And as a nurse, I feel really strongly in my role, always as a translator, about keeping us grounded. So we've included photos of our tribal lands and people in today's presentation. I hope you really enjoy this and respect these as I do. These pictures remind us that we were talking about our tribal brothers and sisters, as well about the systems that affect their lives. There's great variation in size, location, culture, language, and economic opportunity among the 29 federally recognized tribes of Washington. So for example, in the middle of the state, the Confederated Tribes and bands of the Yakama Nation have a reservation that covers over 2,000 square miles. Before they were moved onto the reservation, they were semi-nomadic peoples, more culturally aligned with Great Plains Indian tribes. In the winter, they lived in pit houses, and in the summer, teepees and lodges. Their economy centered on hunting and gathering on a land base much larger than the reservation in today. In contrast, the Makah tribe at the very tip of the Olympic Peninsula has a reservation of less than 50 square miles. I've visited there not too long ago, and it is just extraordinary. It's bordered on the north by the Strait of Juan de Fuca and to the west by the Pacific Ocean. And before the Treaty of Nia Bay, the Makah people lived in long houses and maintained permanent villages. Much of their food and economy then and now centered around the sea, including salmon, seals, and whales. I was really honored and touched to join them in their tribal celebrations and their traditions. We really feel strongly that it's important to keep honoring their connection to the land, to honor their spirituality and their preferences, and to really work side by side in partnership. I'm going to ask Jesse now to start us off with a discussion of terms that you're going to be hearing in this webinar, because if you're like me, there's a lot that we need to do to keep learning. I'm part of the Lifelong Learning Club, where we're just always trying to improve our understanding and sensitivity and competency. So Jesse, I'm going to hand it over to you.
Thank you. Thank you, Sue, and good afternoon, everyone. Can you hear me?
Yes.
Perfect. To start, we're going to discuss a few terms. The state of Washington uses the federal terms tribe or Indian tribe, as in the 25 federally recognized tribes of Washington, but language regarding specific tribes varies. Some federally recognized tribes use the word nation, as in tribal nation or Indian nation. Some use the term Indian tribe or tribal community, as with the Swinomish Indian Tribal Community, which is a federally recognized tribe, and we have a photo from the Swinomish Reservation. Regardless, every federally recognized tribe is a sovereign nation. Tribes also differ in the terms of for their elected leaders. For example, some tribes have presidents, and other tribes have chairs or chairpersons of their tribal council. Tribes also differ in the terms for their legislative body. Some tribes have tribal council, and other tribes have business council. The tribal council makes the tribe's laws or codes, and for many tribes, the tribal council also appoints someone to serve as a tribal administrator or tribal manager. So this is a little different from having an elected leader in the executive branch. When speaking about individuals, Washington State uses the federal terms American Indian and Alaska Native. Many of these people are members of one or more federally recognized tribes, meaning that they are citizens of both the United States and their sovereign Indian nation. In other words, while the term American Indian may refer to a race or ethnicity, it also refers to a political status, which the Supreme Court clarified in the 1970s. In any context, language varies, and it's important to use words correctly. In Indian country, it's also important to understand that when you've seen one tribe, you've seen one tribe. The term Indian Healthcare Provider, or IHCP, was introduced by the federal government several years ago. It refers to three categories of healthcare providers. All three are funded to varying degrees by congressional appropriations through the Indian Health Service. Before this change, the term was I/T/U, which referred to the same three categories. The I stands for the Indian Health Service, which is the federal agency that still provides direct care services to IHS-eligible individuals. These facilities have federal employees, and they are operated by the federal agency. While the agency works with the tribe, the agency is separate from the tribal government. And so for the three tribes that have that, it's important to remember that distinction. The T stands for Tribal Health Program. In this case, a federally recognized tribe has taken over administration of the program under a contract or compact with the Indian Health Service. These contracts or compacts are authorized by Congress in Public Law 93-638, which is why you might hear these facilities referred to as Tribal 638 facilities. These facilities have tribal government employees who work with the co-workers in other departments of the tribal government to provide services. And finally, the U stands for Urban Indian Health Programs, which are urban Indian organizations that receive funds from the Indian Health Service to provide direct care services to IHS-eligible individuals. Nationwide, urban Indian health programs receive about 1% of IHS funding. So they supplement these IHS funds, typically, with Federal Health Resources and Services Administration, also known as HRSA funds, by becoming federally qualified health centers, or FQHCs. These programs are nonprofit organizations. Together, these facilities are referred to as Indian Healthcare Providers, or IHCPs. All of Washington's 29 federally recognized tribes are IHCPs. They have taken over some aspect of healthcare from the Indian Health Service. There are 2 urban Indian health programs in the state, in Seattle and Spokane, as well as 3 federal Indian Health Service direct care service units on the Colville, Spokane, and Yakima Nation reservations. All are shown on this map. Even those tribes that have federal IHS direct care facilities have taken over the behavioral health care for their people. For these tribes, the physical clinic is operated by the federal government and the behavioral health clinic is operated by the tribe. Integrating physical and behavioral health care is a particular challenge for these tribes. We now turn to tribal sovereignty, the history, the legacy, and why it matters. So what is sovereignty and why is it important? One of the best explanations I have seen comes from the late Joe Dela Cruz, who was the president of the Quinault Indian Nation and a world-recognized leader in indigenous sovereignty. He said, quote, "No right is more sacred to a nation, to a people, than the right to freely determine its social, economic, political, and cultural future without external interference. The fullest expression of this right occurs when a nation freely governs itself. We call the exercise of this right self-determination. The practice of this right is self-government." Unquote, or I would say sovereignty. So as sovereign nations before the creation of the United States, many, but not all tribes, signed treaties with the United States government. Here is an image of the Treaty of Medicine Creek of 1854. It is important to remember that these treaties were negotiated usually in a language other than the tribe's native language. These treaties were also signed by tribes under the threat of violence and actual violence. In the Washington Territory, before Washington became a state, Territorial Governor Isaac Stevens had the Nisqually tribal chief and his brother executed, hanged, when the tribe refused to sign the treaty written by Isaac Stevens. After that, the Nisqually tribe and many other tribes, but not all tribes in Washington, signed these treaties with the United States government. In 1871, Congress stopped treaty making with tribes and turned that function into an administrative function by the executive branch. Some tribes in Washington state are recognized by federal executive order, and this is the process for federal recognition through today. So treaties are contracts between sovereign nations. To modify a treaty, both nations typically need to come to an agreement on the new terms. Unfortunately, Congress has a long history of unilaterally changing the terms of tribal treaties. In addition, states or local governments or even private companies may take actions that abridge a tribe's treaty rights, which may then get decided in court and sometimes get decided against the tribe, sometimes without justification. This long history of the United States violating tribes' treaty rights prompted Justice Hugo Black to write in a 1960 Supreme Court opinion that great nations, like great men, should keep their word. He wrote this in his dissent. Every one of these treaties involved the tribes giving up their rights to a larger land base and their rights to enter into treaties with other countries, while keeping some lands along with hunting, fishing, and even whaling rights. In fact, the very term reservation refers to the tribes keeping, reserving their rights to certain lands. In exchange, the United States promised compensation in the form of cash and free health care. The language of the treaties refers to specific provider types. For example, the 1855 treaty with the Yakima promised a hospital, which they have never received. Due to the treaties being negotiated under duress, Congress and the federal courts have over the years recognized that the United States has special trust responsibility to American Indians and Alaska Natives. Or to put it differently, from the perspective of American Indians and Alaska Natives, tribes traded their land as a prepayment for free health care for their people into perpetuity. In other words, free health care is a treaty right. Yet, the United States has never sufficiently funded the Indian healthcare system. You can see here, it is the most underfunded health program in the country. This chart compares the national per capita spending on healthcare. The black line, the second line from the top, is the total amount spent on healthcare in this country divided by everyone in the country. The increase from year to year then reflects the average inflation for healthcare services. The blue line at the top is the total cost of healthcare per capita for the Medicare program. And the green line, the second line from the bottom, is the total cost of healthcare per capita for the Medicaid and CHIP program. The red line at the bottom is the per capita funding to the Indian Health Service for healthcare services, which funds all three categories of Indian healthcare providers to varying degrees. As you can see, it has not kept up with inflation, and more importantly, it is less than half the amount spent for Medicaid clients per capita. As a result, Congress has used third-party revenue in general, and the Medicaid program in particular, as an increasingly important source of revenue to supplement Indian Health Service funding and make all Indian healthcare provider programs more sustainable. This makes Indian healthcare financing extremely complicated, as Indian healthcare providers must comply with federal requirements along with different requirements for each third-party revenue source. This has also led the federal government to enact legal protection specific to American Indians and Alaska Natives and specific to Indian healthcare providers to address issues that arise from this complexity. These legal rules add to the complexity of Indian healthcare. In the meantime, tribal council members, elected officials of different tribes, work tirelessly on health and healthcare-related issues at the federal and state levels, and they continue to fight to protect the rights that the federal government agreed to in their treaties, including adequate funding for the Indian Health Service. Vicki Lowe will now discuss HCA's collaborative work with the American Indian Health Commission to help ensure that the Medicaid transformation efforts by the Healthcare Authority respected the work already done and already being done in Indian healthcare.
Good afternoon, Kwati. Vicki Lowe, Sikislam New Clients, and good afternoon. I'm Vicki Lowe of the Jamestown S'Klallam tribe. I'm also Skokomish and Bella Bella First Nations from Canada. I'm happy to be here with you to share some of the work that we're doing. And if you go on the slide, these are the 4 objectives outlined in the special terms and conditions for the Medicaid Transformation Project, and they apply to the entire project, including the Indian healthcare providers. So only one that does not apply is the objective relating to value-based purchasing. As Jesse mentioned, tribes traded their lands as a prepayment for free healthcare for their people into perpetuity. As such, purchasing of healthcare within Indian country happens very differently than for the general population, and the value-based purchasing objectives do not translate. As we have seen, tribes and the American Indians and Alaska Natives have very different relationships to the state and federal government, healthcare purchasing, and healthcare systems. So the Indian healthcare provider specific projects have their own set of objectives under the 3 larger Medicaid transformation objectives. The first bullet in this slide recognizes the importance of Indian healthcare providers being able to participate in the Medicaid Transformation Project on their own terms, with their own funds. In the second bullet, we're talking about the Community Health Aid Program, referred to as CHAP model, which includes dental health aid therapists. The CHAP model is only operating in Alaska, but we are working on bringing it to the lower 48. This slide also refers to electronic health records. The federal government gave Indian healthcare providers an electronic health record system called the Resource and Patient Management System, or RPMS. This is an antiquated system. It used to be the Veterans Administration and the Indian Health Services were on the same system. The VA, however, is moving away from RPMS, and it is not clear what will happen to all of the Indian healthcare providers who are still using RPMS. Over time, each individual Indian healthcare provider has developed and morphed RPMS to fit their needs. And so RPMS prevents them of the delivering whole person care, and it does not easily exchange information with non-tribal systems. A new model, Tribal 638 FQHC, Federally Qualified Health Centers, proposed by Centers for Medicare and Medicaid Services is expected to provide financial sustainability to these projects after the 5-year Medicaid Transformation authorization expires in 2022. Finally, the adoption of the National Tribal Behavioral Health Agenda supports the behavioral health outcomes of American Indians and Alaska Natives. This agenda came through a collaboration between the Substance Abuse and Mental Health Services Administration, or SAMHSA, and the Indian Health Services and the tribes. So here are the projects selected by tribes and urban Indian health programs. Indian healthcare providers were not required to follow the Medicaid Transformation Toolkit, but we will show later today how these projects do align with the Medicaid Transformation Project objectives. Now I'm going to hand it over to Aaron Sparks from the Seattle Indian Health Board to talk about the National Tribal Behavioral Health Agenda.
Thank you, Vicki. Welcome, Jemai, Puyana Dailuchi, Puyana Samuel. My name is Aaron Sparks. Welcome. And I'm the Government Affairs Officer for the Seattle Indian Health Board. In this final stretch of today's webinar, we thought we would introduce you to the National Tribal Behavioral Health Agenda and help you see how the Indian healthcare provider-specific projects fit in with the national efforts of tribes for a culturally and historically informed framework to help American Indians and Alaska Natives with mental health and substance use disorder needs to recover and heal. It's very important here that we talk about a culturally attuned framework. With 573 federally recognized tribes, there's no one way to do this, so there has to be a fluidity when we're at the creation phase. This quote from the National Tribal Behavioral Health Agenda captures, I think, the spirit of how best to develop behavioral health policies and programs for American Indians and Alaska Natives. As Indigenous people, we possess the culturally relevant knowledge and expertise to address and enhance the overall health and well-being of all American Indian and Alaska Native people across the country. Or as I like to say, the problems in Indian country will be solved by Indian country. So on this next slide, we're looking at the National Tribal Behavioral Health Agenda as it is. Sorting these projects according to the categories is a way to honor and prioritize the needs of Native people in that culturally attuned way. So this first one, historical and intergenerational trauma. Addressing the health concerns of the American Indian and Alaska Native community cannot be done without first acknowledging and understanding how trauma has occurred and continues to get handed down. This is a very recent aspect. I do say this personally. My mother went to a boarding school, so this is not that long ago that we're talking about this. Historical trauma runs very deep, and it's also very apparent for our community. Elders' care and coordination do fit into this model. Also looking at the socio-cultural and ecological approach, we also cannot address health issues without looking at the whole system within which people exist. This aspect where there's money going into projects, couple that with 5415, facilities funding from the IHS, all of these aren't funded at the level that we need them, but it's helping us get to that place where infrastructure is being addressed. Childcare is one of those areas. Prevention and recovery support. American Indians and Alaska Natives also know that solutions must come from the community, as I just said. Very important in this area that we're looking at different boards that are looking at this, the Northwest Portland Area Indian Health Board, along with the American Indian Health Commission, with the CHAP Board, community health aid practitioners, behavioral health aid practitioners. These are all areas in which we're going to start seeing some investment. The next one, number 4, behavioral health systems and supports. It's only one of the foundational elements focusing directly on the behavior, because we know that behavior is just a manifestation of what is occurring around a person. In behavioral health integration, we're starting to expand the 638 clinics, or the 638 FQHCs, traditional Indian medicine programs, dental integration, care coordination, telemedicine, workforce development, along with that CHAP board, and then integrating behavioral health and law enforcement. This last section is national awareness and visibility. One thing I've heard more recently is visibility is the new discrimination or racism. So it's important for tribes and American Indians and Alaska Natives to raise their visibility across communities, states, and across the country. This is very, very poignant right now. In the report that we had recently, Missing and Murdered Indigenous Women and Girls, we found that Native people are disappearing 3 distinct times in their deaths, in law enforcement reporting, and in the media. So it's very important that we pay attention to this. And on this last slide that I'm going to talk about, we can see that the project fit within the Medicaid Transformation objectives as well. So while it took time to figure out how the Medicaid Transformation project would end up working in Indian country with concerted and collaborative effort, we figured out a way to avoid collision. We're very lucky in the state. We have the Centennial Accord. We now have the Governor's Indian Health Advisory Council, where we have access to the governor and the secretary, the state legislature, the Healthcare Authority Administration, and the tribe all working together to better our health outcomes. I'm going to hand it back to Sue Birch for some closing thoughts before we enter the Q&A portion of the program.
So thank you to my esteemed colleagues, Erin, Vicki, Jesse. I just want you to know that we so appreciate you and have just enormous gratitude for how passionate and committed and dedicated you are to our partnership and our work going forward. This presentation has been very eye-opening for me, and it is also, it calls me to do more to try to equalize out the disparities. I think we, HCA, and the IHCPs have demonstrated with this particular project how we can come together with time, deep listening, and a willingness to adapt to really improve the health of everyone living in this diverse and spectacular, beautiful state. Thank you again for all the staff that make this possible. I really have loved our slides today. And again, I have so much gratitude for the abundance that we have in the sharing and the commitment and the partnership. And let's keep going forward and really keep trying to repair and to honor the work that has been done before us. I think now I'm going to turn it back over to Rochelle.
All right. Thank you, Sue, and thank you for our other panelists. This has just been a terrific presentation. We are getting some questions coming in, and bear with us. For those of you who are listening, we are actually Skyping with our colleagues over in Spokane right now, so there's going to be a little bit of a lag time between me typing out the question and them responding. So bear with us. One of the first questions that we received earlier on from one of our attendees was, will the preferred language be available on a document? That would be really valuable when developing education provided to staff. And yes, absolutely, we will work with Lena and Jesse and that crew to do that. And we will also have that PowerPoint available on our website as well. So you could certainly use that as a tool and share that with other folks. Okay, so hang on. I'm going to be sending over some questions over to our folks over in Spokane. But please continue to send us your questions. They are wonderful.
So Jesse and Erin and Vicki, this is Sue, and while Rochelle's kind of typing in things and getting situated there, I'm just wondering, do we have any unique tribal celebrations coming up in the next 30 days?
You're unmuted.
Jesse, this is Sue. Can you hear me?
Yes, we were muted, sorry. So we do have the canoe journey coming.
Yes, hi, this is Vicki. I actually participate in the canoe journey and have since, well, since 2002, but been traveling with our canoe family. And the canoe journey is a way for the tribes, the Salish tribes, to come together and practice the traditions of our ancestors. And I like to go because I get to be Indian and not have to explain myself, which I think is really important. And so we will be, each tribe leaves from its own traditional lands, and we will be traveling in the Salish Sea up to the Lummi Nation for a celebration at the end of all of our travel.
And I do want to point out that on June 8th at the Seattle Center, the Seattle Indian Health Board is hosting the 2019 Indigenous Peoples Festival. That is from 11 a.m. to 5 p.m., where you will see a lot of different cultural performances and messages from our community. It's a great day. We've been doing this for a couple of years now, and we invite everybody to come down and learn more about our urban Native community as well as the Native community throughout the state of Washington, as well as nationally. We have a lot of different artists. We have a lot of different speakers, so it'll be good for anybody who's in the area at the time to come on by.
And these are some of the bigger events, but almost every tribe also has festivals. I know the Makah tribe has Makah Days, and so different tribes will put their festivals on their website and on Facebook, and people are always welcome to attend any of these festivities.
So we have a couple questions that have come through. First question, how are we capturing who may be identified as a tribal native? Is it status, registration, self-reported, etc.?
This is Aaron Spark. It's basically all of them. So we're still at the point where we're really trying to get an actual system down where we're able to track how people are identified. So at our urban Indian health programs, we do allow people to self-report depending on the programming that we have. And that's because we have IHS funding where we can create specific programming for our Native people. Each tribe or anybody in our ITU system of care has the ability to figure out how they're going to do that. There is no one way quite yet, but once you're into the health plan finder, there is a way that you report, and they can come up with documentation in order to qualify for Native specific provision.
Yeah, and at the same time, if they when they're in health plan finder, if they qualify for Medicaid, they do not have to provide the documentation to show that they're enrolled in a tribe. And so that then becomes, for the Medicaid program, a self-reported field. The identification is one of the most complex and challenging issues in all of healthcare.
Thank you.
So
Our next
Jesse,
question, go ahead, Sue.
So Jesse and Lena and Vicki and Aaron, I think also the takeaway for everybody that's listening in is that we really want to encourage people to self-identify and to really be proud, because it really impacts our ability to pull in more resources. And so we really want to be extra encouraging. And I am just also wanting to catch up real quickly. I received a text saying, don't forget to announce the Veterans Powwow at Tulalip on May 31st. So I don't want to leave anybody out. And I love when I get these real-time texts, and just putting in a plug for that as well. Thank you. Go ahead, Lena.
Thank you so much. Next question, what are some tangible actions that advocates can do to push for equity in the Native healthcare system?
I think one of the things that we keep talking, when we go visit ACHs, is being patient and always having a place at the table, be welcoming, include them, even if they don't start showing up at first, because it takes time and you need to build relationships in order to have that trust relationship. And then once that happens, that's where you can actually have an impact.
Yeah, and I think a lot of that is partner development as well. So I run our policy program at the Seattle Indian Health Board, and we make sure that we work with our tribal, community, and government partners from the local to the national level, where we join in with their advocacy efforts, and in turn they join in with ours, to the point where you're working with people so intimately that you do not have to be in the room with them anymore to deliver your talking points, your very necessary policy points. So that's been helping a lot lately, to make sure you're working with other folks. You can't do this. This doesn't exist in a vacuum. You need your community to do it with you.
And I would second that and talk about, and what adds that, it's really important when you're developing programs that the tribes and the urban Indian health programs are at the table, and that you're working in a collaborative manner. They have the expertise in working in Indian country. And so when programs are developed without their input, it really just can be a misfire or worse.
Yeah, so I'm looking at a question, can you provide specifics regarding the work tribes are doing with Medicaid Transformation and ACHs? So you saw the list of our projects that we have here, but we do work with our ACHs. We encourage everybody to take part in, because those are federal funds. Now, initially when this happened, that was federal funds that were divested down from the state level to these public-private partnerships. So we had to kind of fight to make sure that the tribal piece was in there. And after that fight, we wanted to make sure that we're working collaboratively as partners with people to make sure that our Native community is still going to benefit from the ACH project. So like in the King County ACH, my CEO, Esther Lucero from the Seattle Indian Health Board, is the co-chair of our ACH to make sure that our Native community is included.
Yeah, and I would add the different ACHs have worked with tribes in different ways, and not all tribes have been very interested in working with ACHs. I'd say most have, but they all, wherever a tribe has been interested in working with ACH, I think like Vicki mentioned earlier, it's important to just work with them, keep the door open, and figure out what their priorities are so that you can supplement their efforts.
Right, and also understanding the complexity of the tribe and their jurisdictional areas don't necessarily fit with any one ACH. So I like to use Steve Kutz from College Tribe as an example here, because I think he can attend about 4 different ACH meetings and advocate for his people.
Right. And also that, the time that it takes to attend all the meetings, and remembering the slide with Andy Joseph from the Colville Tribe and all the other obligations he has to advocate for his tribe. So sometimes there's just not time, so keeping the communication there is really important. Okay, so the question is, if federal health care for American Indians Alaska Natives is not insurance, how is health care available outside the clinic? So there's 2 buckets of money that we get to provide care, and I'm talking specifically for Tribal 638 tribe, that's where I come from. And one is direct care, and that funds the clinic and the providers and the work they do. And the second bucket is called purchase and referred care, and that is very limited appropriated funds, so when they're gone, they're gone. And the tribal program buys the services outside of the clinic, which since the Affordable Care Act, we're allowed to use those funds to purchase insurance. So a lot more now you will see tribal members on insurance when they're referred outside the clinic.
Mm-hmm. I'm seeing, what is the best way to share youth and orphan training with healthcare staff who are serving tribes? That's a really interesting one. Some of us in our behavioral health programs already have that implemented. So reaching out to those of us who have already successfully done it to also work with our ITU partners is a very good place to start. But you do have to reach out to the behavioral health aspect, but depending on what tribe you're talking to, they might not even have the program or have the background. So it depends on who you're talking to and what level you're going to have to go at. You could be starting at ground zero when you're talking to some folks.
And they could also be getting that training through IHS.
Right. Yeah.
And I did mention a replacement for our, go ahead, Sue.
Oh, I'm sorry, Vicki. We're so eager because we're getting such great linkages. I think my tribal brothers and sisters know that I need to play some more, so I'm getting to notice that the Nooksack tribe on Friday, May 24th at 11 a.m. is hosting a Veterans Recognition event in the community building in Everson. So we are going to list all these upcoming events in our follow-up email. So please, if there are others that are coming up, please get those to our team, and we will make sure to push those out via email. Go ahead, Vicki.
Okay, thanks, Sue. So there's just a statement saying that did somebody hear me say our PMS is going to be replaced? And we just had a workshop yesterday here in Spokane with Tribes and Urban Programs to talk about electronic health records and what the future of that looks. There's not really an answer yet. IHS has not said that they're getting rid of our PMS, but we don't know how it will continue. So we're really looking together and trying to figure out what is going to be the solutions for that. Only 17 of the tribes right now are using our PMS fully as their only EHR. Many tribes have moved to commercial off-the-shelf EHRs, or they use our PMS for certain parts of it and then have cobbled together some other EHRs with that to get their needs met.
And this is happening at the national level too. There's an IHS task force in the House in DC looking at the EHR issue. So there's money allocated last year to bring together a work group to figure out how this is going to work. In my opinion, yes, RPMS is going to be replaced. It's not an opinion. It does not have technical support for it anymore. So the current version is going to sunset. And that last year, from what we heard, Cerner was the EHR that they had agreed on, but that did not go through tribal consultation. So this is all still up in the air. The tribes have yet to weigh in on what's going to work for them. I know that the Seattle Indian Health Board, when we gave our feedback, we said it has to work for the system that you're in. Because we're a community health center as well as an urban Indian health program, it's very important that we're able to connect to different state systems. So we're looking at other third-party EHRs that are going to make sense for us, like Epic or NextGen.
But again, disclaimer, IHS has not announced that RPMS is going away, but we're not dumb.
Yeah.
We can't see how it can keep going. It's a dinosaur. It was built in before the 70s, and it was high-tech at one time, and now it's not.
So this is Sue. I have a great question that's come in. The question is, will ACHs, the Accountable Community of Health, and the Healthcare Authority be amenable to considering evidence-based practices other than those previously identified for care coordination projects? And specifically, if the tribes can find culturally appropriate models of evidence-based practices, will we be open? And yes, we will absolutely want to hear about those. And I believe things like family spirits and where we have evidence-based programs, we do acknowledge and make exceptions. So please, if you have other evidence-based practices that are culturally appropriate that we need to know about, please enlighten us, and we will work with you to see if we can get those approved.
Thank you, Sue.
Back to you. Okay, Ann.
Okay, so who is eligible to use urban Indian health clinics and who can use a reservation? Again, that is up to the site that you're talking to. So the urban Indian health programs, both the Native Project and the Seattle Indian Health Board, we're community health centers. So anybody who walks in can use us. We just do it in a very culturally attuned way. So the Seattle Indian Health Board, we say it doesn't matter who walks in the door, we're going to serve you the native way. But the tribes themselves, they are the ones who can say who can come in and who cannot. Open, you can, any native can walk in and get services, but others, they're limited to their people. Again, a lot of it has to do with funding. And remember, we're woefully underfunded, about $3,400 or $3,800 per capita in the IHS, as opposed to over $10,000 for everybody else's medical spending. So the funding issue is very prevalent, and it's up to each site to figure out who they're going to see.
Thanks, Erin. So the next question is about tribal clinics being exempt from value-based contracting. So remember the slides that Jesse showed where the funding for IHS was way below everything else. So that's been estimated at 32% of the level of need. So 32 cents for every dollar. Think of it that way. And then so that's part of the funding for healthcare. And in order to make up the difference, we bill Medicaid, Medicare, and private insurances, car insurance, anything that we can get paid from, seriously. But with Medicare and Medicaid, we can get encounter rates. And the Medicaid encounter rate is established at the federal level across the country. It's different in Alaska, it's a little more. But and so we rely on that encounter rate to keep our programs going. It's the cash flow for the clinics to pay the staff every week, every 2 weeks, every month, and we need it for our operations. So value-based payments don't fit into that. I mean, we pay for value in the way that we take care of our people, each tribal clinic, each urban, in the way that we know they need to be treated. We have been providing whole person care for a lot longer than it was called whole person care. I know it was a new concept to some people. Were like, hey, we're already doing that. But so value is built into our system because we see our people from life to death. We, you know, tribal clinics, you can't fire a tribal member as a patient. You got to figure it out. So it's a very different system, and we got to make it work. So I hope that answers the question.
Well, we also have a lot of chronic conditions. So when you look at the value-based contracting aspect or the negotiation that you walk into, we still haven't gotten to a point where primary care is preventative medicine yet. So there's a stabilization of our population that we have to go through. So when you're doing the numbers in your head for value-based purchasing or contracting, it doesn't work for a Native community because a per member per month aspect, you're gone immediately. You have to stabilize conditions first, and that's a very expensive prospect. So at the moment, we're just not ready for that. We have to get to the point where we're stabilizing first.
Thank you, Aaron and Vicki, for that perspective. Here's a question that came in, and I think this probably needs to be our last one, and then I'm going to turn it back over to Rochelle to do the final wrap-up. But the question came in, do the needs of American Indians that are on Medicare, not Medicaid, who use tribal health services fit in any way into the Medicaid Transformation ACH efforts? And yes, they absolutely do. The accountable communities of health are broad-reaching, and through chronic disease programs or the opioid initiatives, behavioral health integration, all of those things tie in to enhancing the fabric of our community supports. Specifically, too, in the Medicaid Transformation Project, there are some services for aging, supportive employment, and supportive housing that Medicare recipients might be more eligible and appropriate for. So again, whoever asked this question, I really encourage you to reach to any of the community partners, the ACHs first, any of our MTP staff, Jesse, Lena, and others as well, some of the Older Americans Act aging programs. There are just a variety of resources that might be appropriate for Medicare recipients. So with that, I'm going to turn this back over to Rochelle to do our closing and make sure she captures all the next steps here.
All right, thank you, Sue. And again, thank you to our wonderful esteemed colleagues over in Spokane, and thank you all for being on the call today. We hit a bit of a record today. We had almost 450 registrations for this particular webinar. And so not everyone was able to tune in or was available, but we will be sending out a follow-up email that will have a link to actually listening to the recording of this presentation and also have the presentation as well. So that will be coming to you. And we would love to have you join us for a future webinar. I think we have something coming up in August. We'll be sending out some information on that as well. And please feel free to visit our website to learn more about Healthier Washington. Under our How to Participate page, you can go in, you can sign up for receiving our communications we send out, and you can email us. You can also connect with us on social media and use our hashtag HealthierWA. So thank you so much again for taking time out of your lunch hour to spend with us, and we look forward to seeing you next time. Thank you.
Thank you, everyone.
Thank you.
Thank you.